Whoa, talk about fast and ferocious. We've wandered onto the set of the 27th installment, which frankly, they definitely have room for at least 11 more sequels and make that 7 more spin-offs. With all those cars flying around and breaking things, it's the perfect place to talk about pelvic fractures. Oh, wait, shh, everybody be quiet. I think they're rolling. And cut. Epic crash. It's done. But speaking of car crashes, turns out they're one of the most common causes of pelvic trauma, particularly the high-speed ones, which, to be honest, is what the Fast and Ferocious is all about. This now falling car should remind you that falls from heights also commonly cause pelvic fractures. With this severe trauma, patients with pelvic fractures often have multiple significant injuries called polytrauma. But don't forget that elderly patients, especially those at increased risk for fractures, may get pelvic fractures during falls from standing height as well. On exam, patients will have pain and instability with pelvic compression. To remember this, look at our stuntman, who's fallen awkwardly onto his hip, causing pain and compressing the pelvis-shaped crash pad. And when lying straight on the gurney, a tilted pelvis or a shortened leg on the affected side can be observed, like our friend's leg tucked underneath him. Hematomas are another common finding on exam. If you observe a perineal or inguinal hematoma, these indicate a higher likelihood of deeper injuries, including fractures. Flank hematomas may also be present. This stuntman's red harness should remind you exactly where to look for hematomas. As with any trauma patient, the FAST exam is extremely important, especially in those with hemodynamic instability, since its purpose is to identify intraperitoneal fluid. But recall, the FAST exam isn't great at identifying retroperitoneal hemorrhage, and pelvic fractures can easily disrupt the vast plexus of veins running along the inside of the pelvis, which causes, you guessed it, retroperitoneal hemorrhage. Our director is sporting our recurring FAST metal detector wand, and it's broken, to remind you that in patients with pelvic trauma, hemodynamic instability with a negative FAST exam suggests retroperitoneal hemorrhage from pelvic fractures. But to keep things extra confusing, a positive FAST doesn't rule out retroperitoneal hemorrhage, since patients can have hemodynamic instability from multiple sources. FAST is written in all caps in our movie's title, to remind you that even with a positive FAST exam, you shouldn't rule out a pelvic source of hemorrhage in patients with significant pelvic fractures. Instead, maintain a high clinical suspicion for this in patients with pelvic trauma. Woohoo! Look out below! We got a villain on the loose, and he's got 9 lives. His hardcore leather skull and crossbones jacket should remind you of the good old X-ray, which is the fastest imaging modality to identify pelvic fractures. And since the pelvis is essentially a closed ring, fractures through the ring itself are rarely singular, so look for asymmetry to clue you in on where the fractures are. If your patient is stable, a CT abdomen pelvis is going to provide improved details about the fractures themselves, and can even give 3D reconstruction views, which can be important for planning definitive repair, but that's getting ahead of ourselves. First, we have to address the elephant in the room. These are trauma patients, and usually polytrauma patients, so they can be incredibly sick with multiple life-threatening injuries. As with every trauma patient, management begins with the ABCDEs of the primary survey to identify and manage the most immediate life-threatening injuries, symbolized by our recurring ABCDE license plate. For pelvic fractures specifically, the most important first step is to manage any ongoing hemorrhage, and it can be a little challenging, like trying to keep all these storylines together. That's why our frazzled script supervisor is here holding onto this giant binder to make sure our story sticks together. All this binding should remind you of a pelvic binder, which is used to close down the pelvic vault and tamponade any bleeding sources. Binders are not used to reapproximate the fracture fragments, but rather to temporize the bleeding so that other injuries can be addressed. Our script soup is also looking to keep track of all the storylines by using this black and white map, which sure looks a lot like angiography. How convenient, given that angiography is both diagnostic and therapeutic for pelvic hemorrhage. This is helpful in unstable patients that can't go to CT, since the bleeding vessels can be embolized once they're identified to stop the hemorrhage. If no active bleeding is seen, but the concern for pelvic hemorrhage remains high, the bilateral internal iliac arteries can be embolized safely to control the bleeding. Once hemorrhage is under control, the pelvic fractures can be addressed. Fractures are classified as stable or unstable, not to be confused with hemodynamic stability. Stable fracture patterns are ones that don't affect the stability of the pelvis. Just like this column has a crack in it, but it's not really affecting the column's job of holding up the building. Like a pubic ramus fracture, or a fracture that doesn't disrupt the structure of the pelvic ring. These fractures are usually managed non-operatively, with a focus on pain control, early physical therapy, and bed rest. A therapy this production assistant has taken to heart. Unstable fracture patterns, on the other hand, are ones in which the structure of the pelvis is damaged such that it can't support the body's weight, like this column cracked all the way through that's about to collapse. Unstable fractures require surgical repair, which is usually done in a stepwise fashion. Initially, an external fixator temporarily reapproximates the fragments so that the patient's other injuries can be addressed. This PA is demonstrating this concept by trying to externally fix this column. PA is just as good as an architect, right? Yeah. Besides, they don't have to hold it forever. It's just till the last shot, right? Like, 10 more takes, maybe? Once other injuries are managed, a delayed definitive surgery, like an ORIF, or open reduction internal fixation, can be performed to more definitively repair the pelvis. Open fractures, or those with significant related injuries, also require surgery. Patients with pelvic fractures are also at high risk for venous thromboembolism due to their polytrauma and prolonged immobilization. So, get that clog begun in there. Of course, in medicine, we use heparin and enoxaparin instead of caustic car chemicals. And only once any hemorrhage is controlled. If there's still a concern for ongoing hemorrhage, an IVC filter for mechanical prophylaxis is an alternative. And finally, let's do some takes where we address all those other types of injuries associated with pelvic fractures that we keep alluding to, since up to 60% of patients with pelvic injury have polytrauma. This stunt car, with its litany of wrecked parts, represents these associated injuries, which include GU organ injuries, especially bladder and urethral trauma, neurovascular injuries to vessels passing through the pelvis or to the lumbosacral plexus, abdominal injuries like to the liver, spleen, or bowel, abdominal compartment syndrome, and axial and long bone fractures. In a word, yikes. Well, looks like things are about to wrap up on set. We might want to get out of here before that PA lets go of the column. But before we do, let's review. Pelvic fractures are most commonly associated with severe trauma, like high-speed MVCs or falls from heights. Clinical findings include pain and instability, a tilted pelvis or a shortened leg, and pelvic hematomas. Importantly, pelvic fractures may commonly cause retroperitoneal hemorrhage and hemodynamic instability, but since the bleeding is retroperitoneal, it won't be identified on FAST exams. A high suspicion is necessary to identify patients who may have retroperitoneal hemorrhage from pelvic fractures. Pelvic X-rays are the fastest imaging to identify pelvic fractures, particularly in unstable patients. CT scans of the abdomen and pelvis are more detailed and can give more information about the fractures themselves, but should not be performed in unstable patients. Management of all trauma patients, including pelvic trauma, should begin with the ABCDEs to identify and manage the most life-threatening injuries first. Hemorrhage should also be managed before addressing repair of the fractures. A pelvic binder may temporarily tamponade hemorrhage while other injuries are being addressed. Angiography with embolization is a more definitive solution for hemorrhage control. Management of the fractures themselves depends on the fracture pattern. Stable fracture patterns typically are managed non-operatively with pain control, bed rest, and early PT, whereas unstable fractures require surgical fixation, often initially with temporary fixation like an external fixator, with definitive repair performed in a delayed fashion. Finally, these patients require DVT prophylaxis once hemorrhage is controlled, and there should be a high suspicion for associated injuries, since pelvic fractures frequently are associated with multiple other injuries. And before we go, let's kick back, have a Corona. Cheers to 27 more installments. You guys are like family. And I'd do anything for my sketchy family.